Good evening, gentlemen. We are very sorry for that delay. I would like to welcome all of you to our webinar today, Spectrum of COVID-19 Disease and its Future Perspectives, organized by the College of General Practitioners in collaboration with Dr. Reddy's Laboratories. And today, I would like to welcome our resource person, Dr. Kapila, consultant physician from the General Hospital, Martale. Good evening to you, sir.
Good evening.
Dr. Kapila Dialvis is a student of St. Sylvester's College, Kandy, and he entered the Faculty of Medicine, Peradeniya in 1982 and completed his undergraduate studies in 1990, obtaining second-class honors in all exams, including the final MBBS, and obtained the Doctor of Medicine from the University of Colombo in 1999 and became a board-certified consultant physician in 2001. And he went for overseas training in Southampton University Hospital in the United Kingdom in 2001 and completed his membership in 2002. And he was honored with a fellowship of the Royal College of Edinburgh in 2009, served as a consultant physician in Base Hospital Dambulla, Gampola, General Hospital Kegol, and presently working at the District General Hospital Martale as a consultant physician. So his special interests are in the management of infectious diseases such as leptospirosis, dengue, and COVID-19 pneumonia, which has paved way for him to publish research papers in peer-reviewed journals, and especially on high-dose methylprednisolone therapy in leptospirosis and dengue. And presently, also, he's working on research work related to COVID-19 pneumonia. Over to you, sir.
Good evening, ladies and gentlemen. It's my pleasure to join your webinar, organized by the Sri Lanka College of General Practitioners and in collaboration with Reddy's Pharmaceutical. I extend my sincere thanks to both the groups, and I would start my lecture now. It's on spectrum of COVID-19 disease and the future perspectives, and especially the challenges posed by Corona-19 pandemic to clinicians like us and you all, everybody. So it is a wide topic. I just listed out a couple of subtopics. I hope that I would be able to cover all these things in a summary style. And these are my 7 topics I'm going to discuss today, starting from COVID viral disease to ending at post-vaccination illnesses. So I would like to share with you one of our clinical experience. In fact, it's the first one when we started managing the COVID patients from the onset of this pandemic, start of the pandemics in January 2020. But we got the most desaturating ill patient in December. Until such time, we just dealt with some viral fever syndromes. Now, this gentleman was 34 years old. He presented with cold and cough for 10 days. He had waited 10 days taking treatment from GPs. When he ended up with progressive dyspnea, which he couldn't tolerate anymore, when it got worsened over 4 days, he came to the hospital to be seen by us in the middle of the night. And his pulse and blood pressure was normal, but he was a little tachypneic, and his SPME went on to do the basic investigations. We found his blood's lymphocyte count was very low. This gave the first clue that it could be COVID. And then the platelets were normal, but the PCR became positive the next day. And his inflammatory markers were very high. Serum ferritin more than 1,000 and CRP 211 and LDH level 921. All these are the markers of inflammatory process. And you can see that so we started managing him with according to the guideline the Ministry of Health guidelines, we started giving him oxygen 6 liters per minute. We made him prone positioned with IV fluids, aspirin, atorvastatin, and vitamin D, vitamin C, zinc, azithromycin, and the disease-modifying drug, which we started, dexamethasone 6 milligram, according to the guideline. Then his saturation remained low in the whole morning, the next day, 73 on oxygen. 6 liters. Mind you, in the hospital, Matale, and 4-bedded with just some nasal prong oxygen only. So we started on IV methylprednisolone 500 milligram in 1 hour at 1 p.m. The next day for giving over 1 hour. And this is saturation remained in the morning, and he remained in the morning, but 1 hour after giving IV methylprednisolone dose, his saturation shot up to 87, to much of our pleasure. And then by another 7 to 8 hours, it was 93. You can see that. And this is the amazing chest X-ray what he had. The total lungs, almost 80% of the lungs are involved. And the next one is a couple of days after, once the treatment progressed. He improved such a manner. So what prompted us to give this treatment was the help, some kind of information given by the frontline COVID Care Alliance, COVID Critical Care Alliance in America, which is formulated by Dr. Paul Merrick. And this is recommended in his guideline, though here it says that it is 40 milligram BD here orally, when the severe most disease comes, it is IV 500 milligram per day. That's what they mentioned. So you can see the aspirin, enoxaparin, and ivermectin, and very innovative treatments are there in this, and which you can't start these steroids until 11th day of the illness, or until the early pulmonary phase. That is when the patient presents with low saturation. So before that, it is a viremia stage. You are not supposed to start steroids during the viremia state. That is when the patient has fever, malaise, cough, headache, and diarrhea. And so this is very important point I'm raising. So the steroids need to be given in the early pulmonary phase, when the immunological phase is started. So they say that this is a steroid responsive inflammatory disease. So that, but the timing is very critical. So when you look at this diagram, you can see how this oxygen saturation start dropping. This is, mind you, the previous epidemic of not the Delta, but the Alpha at the beginning of the last year. So then they go on to show that inflammatory response comes up towards the 12th day here. You can see that it climbs up, oxygen saturation drops. So having said that, I would like to share another case. Now, as the time progressed, we got combined infections, that is, the leptospirosis presenting in a COVID patient. So this patient was 42 years with fever 2 days and cough, worked in a paddy field, presented with, he's a diabetic with a high RBS, and his rat became positive. He went into acute kidney injury failure with aneurysm. He became anuric over the next 48 hours or so. And his creatinine shot up, and then his urine albumin was positive. This is the clue: low platelets and the urine albumin. Then we started giving antibiotics, ceftriaxone and doxycycline. With this gave IV methylprednisolone 1 for 3 days. This is the experiment, and then it works very well, and he was recovered, and his urine came up, and he recovered from acute kidney injury. Then the next case I want to share is dengue hemorrhagic fever. This is a 29 years old lady who is a nurse, staff nurse from the NHSL, came with fever 4 days and lower abdominal pain. Her PCR was positive, and to our amazement, the NS1 also, antigen also positive. She remained in a normal saturation at 99 on there, but her blood pressure was the problem here. And it was 90 by 50 and further dropped on when she made upright. She had a bit of right iliacus pain also, and then suggesting acute appendicitis, and the platelets were low, and her WBCDC also low. And then we had her enzymes and the inflammatory markers high. We started 40 milligram BD methyl prednisolone, but we didn't have to give oxygen. She recovered very well without much of a worsening of the pleural effusion and leak. So COVID-19 viral disease. This is we are talking about the first 5 days where the prolonged fever and the distress up to about 7 days, the fever is running, and then the myalgia, headache, and sore throat, etc. And the patient become very ill. And we need to give the symptomatic relief. And we need to differentiate it from other infections. And we have to minimize complications, such as COVID pneumonia, MIS-A, that is multisystem inflammatory syndrome, long COVID syndrome as well. And we have to stop transmission to first contacts to minimize the society getting infected. Now, this is the other slide that I want to show you. From day 1 to 7 is the one that where you get the differential diagnosis of viral fever. Day 7 to 14, you have to make the differential diagnosis of pneumonia, from bacterial pneumonia, asthma, COPD, and myocardial infarction and heart failure. Now, when it comes to why I put it as 7 as opposed to the previous slide, when it comes to Delta variant, it is more advanced. It comes very early, the desaturation. The patient didn't wait until 10th day or the 11th day to become desaturated. Then comes day 14 to 21. The main diagnosis is the MIS. Now we encounter a lot of MIS, multi-system inflammatory syndrome. Yeah, in this situation, the patient comes, the differential diagnosis is different. I'll explain with a case study later on, but the septicemia, severe fluid overload, and AKI, and myocarditis and shock. Then comes the lung fibrosis and the long COVID. We'll discuss it later. So the action we take in this type of situation will come to the viral fever. We need to do rapid antigen test. It is most helpful to start with, but its sensitivity could be low. But the specificity could be low, but the sensitivity is good as to, deal with the patient and get on with our job. But when it comes to the acute intervention, surgery, putting him into the ICU and do various procedures, for instance, oropharyngeal, we definitely need the PCR confirmation. So we would go for that, even if the rapid antigen become negative. But for the management of viral fever, we don't want the PCR that urgently. Other than the real necessity was that prevent the community spread. We did it very diligently. Then it comes to pneumonia, it's the PCR more important than the rapid antigen test. But there are, of course, also rapid antigen became positive, and it was very helpful as to manage the patient early, preventing further desaturation. So I'll move to the next one. This slide shows the infectiousness, the patient's infectiousness, that is up to about 8th day, the patient is infective, where the rapid test is positive. And then after that, the PCR start picking up. And then by the 10th day or 12th day, PCR is definitely should be positive. But at the beginning, it varies, and it could be positive, and then later on, the IgM antibodies come. So this is the value of the PCR, especially when it comes to viremia, diagnose the viremia and the viral fever. It's it is the rapid antigen test, and then next it I mean, you can have PCR positive up to by about 4th day, and then it become the mainstay of clinical or the laboratory diagnosis. The other illnesses like pulmonary disease, miss, lung fibrosis, etc. But when it comes to long COVID, you can't expect PCR to be positive because it's already gone by 30th day, and then the antibodies become more important to do. So the differential diagnosis, what are the other things that you do in COVID viral fever? It's a white cell count, I just told, leptospirosis, it's the albumin, and it's typhus, it's the serology, and so on. And dengue, you all know that it's the antigen. In case of it's not non-availability, it's IgM antibodies. Now I come to the therapeutic options, the antiviral drugs. These are the available options. So the one is antiviral drugs. The next one is immunological products, where it comes the monoclonal antibodies, and then the various miscellaneous treatments. We did, use it for the maximum benefit to the patient: vitamin C, vitamin D, zinc, and etc. And then adjuvant therapy, the corticosteroids, which I'm going to touch and in detail. And the drug repurposing has been very interesting that many people got this ivermectin, interest on the ivermectin, and there are a lot of the trials. I will discuss why it is so. Before that, how the drugs can be catered to the patient's illness into the maximum use benefit, we must know the pathophysiology. The virus, when the virus comes and attached to the cell surface, in this picture, ligand binding receptor, and then you can see that I haven't driven the spike protein come and attach to this receptor, and then it comes the JAK2 and then the STATs. So this is transducer activator transcription STATs, the intracellular mediator. Then JAK2. Those are the cellular cytoplasmic, cytosolic places or targets that we can use our various drugs to counter. Then the nucleus. I'll come to the nucleus. That is mainly the pro-inflammatory cytokines are made by the nuclear factor kappa B. So you can see that it's the major component there, target. This pathophysiology again, then once these inflammatory cytokines are made in plenty, and it can cause a cytokine storm. The cytokine storm manifests in various manners. It causes ARDS in the lung, and it can cause DIC, it can cause multi-organ failure, and that is what we see as a miss. And before that, it's the other most important is the pulmonary syndrome, the thrombosis. So again, highlighting these various modalities of treatment, that these treatments should be put into this time schedules. So other disease-modifying drugs, which is not mentioned in that previous one, is remdesivir and favipiravir. And then the CoV-2 is the most, hot topic in America now for the moment, monoclonal antibody regimen, which is casirivimab and indemimab. So these mAbs are very convincing, this reducing the viral load and the infectivity of the virus. Then the tocilizumab and the mAbs, which deals with the intracellular transduction. Then the JAK2 inhibitors, baricitinib is the one which is the most promising, but we have in Sri Lanka tofacitinib, which is very promising. We made use of that, the availability, and then we derived a lot of very convincing results. Then the therapeutic dose of enoxaparin, mind you, and the heparin nebulization do play a role. So prevent vascular complications, this has to be, I want to really emphasize this, though, it's been a thrombotic disease, we need to give aspirin and clopidogrel antiplatelets and statin, statin and rosuvastatin, because both these modalities are very antithrombotic, and meanwhile those are anti-inflammatory. Then I will bring your attention back to ivermectin. This there has been a fair amount of trials has happened all around the world. And to summarize these, there are 64 trials with about 48,000 odd patients. There are 31 randomized trials. And there is fair amount of improvement when it's used. The maximum benefit is in prophylaxis. But when it comes to early treatment, it is promising, again, 66% improvement. And it do reduce this 57%, the mortality. But when it comes to the late disease, severe disease, its efficacy is not that high. And in fact, I think it is the truth at the moment. Then the Oxford Principal trial is a very important trial because people disputed the authenticity and the credibility of these trials, so that Oxford group of investigators thought that there is some case here to be investigated. So there are promising results as a potential treatment in small studies in humans. So they started recruited more than 5,000 volunteers in the UK study. And then they thought that this speed up recovery, reduce the severity of symptoms, prevent the need for hospital admission. And mind you, but in our experience, prevents the transmission and the community spread as well, which is, I mean, amply used in Uttar Pradesh in India. And we had a nice webinar on that recently. It was shown how they effectively made use of that to minimize the burden of COVID. Then comes the American large trial with 5,000, again, odd patients in the active master protocol trial. So they will also come out with their results very soon. So we'll get an answer for this valuable, cheap, and widely available drug, which is non-toxic. I would like to now talk about COVID pneumonia. That comes in the time schedule scale, 6 to 10th day. So our aims of treatment are to shorten the hypoxia, minimize irreversible lung damage, and leading lung fibrosis, and then prevent lung thrombosis, minimize lung damage due to high flow oxygen therapy as well. When you use high flow oxygen therapy, you know that free radicals can cause damage to the lung, and reverse atelectasis of the lung. And we need to open up the atelectatic lung in order to get the oxygenation going, because the lung is mostly thrombosed. And we have to prevent the secondary bacterial infection as well. And then the nutrition and hygiene too are very important. Then comes to respiratory illness. It's again the investigations, you know, that is asthma comes in the contention, then the COPD, so that you use the chest X-ray and lung function test if it's available. Heart failure, and the ECG and NT-proBNP. Then echo study is the most important one there. Investigation, then the bacterial pneumonia, chest X-ray cultures, and serology. Mind you, when it comes to COVID, these investigations are scarce, and it's very difficult to, though the investigations are available in the hospital, very difficult to put it into use because of the constraints due to infectivity of the virus. Treatment modalities for COVID pneumonia is the next topic, and then these corticosteroids, coming to corticosteroids, and the oxygen delivery and non-invasive ventilation. So before that, I would like to again highlight this corticosteroid as a disease-modifying therapy, which again, this trial, which says that dexamethasone versus methylprednisolone high dose would be an effective option in COVID-19 pneumonia. They say that high dose methylprednisolone for 3 days, followed by oral prednisolone for 14 days, compared to dexamethasone 6 milligram for 7 to 10 days, statistically significant decrease the time of recovery is their main finding. The need for transfer to intensive care is less, the severity of markers are brought down, and they say that randomized control trials with methylprednisolone are required to corroborate its effect, and studies in population hospitalized in intensive care. So this having these studies gave some light to us, and then we were keen to deal with our epidemic in Matale. This was our burden. 16,565 cases from the last April, and a fair number of deaths, 450. And this is one of the biggest hit by the COVID-19, one of the cities in the central province. So we started designing a treatment protocol at DGH Mahathale, which was ratified by our steering committee and the ethical committee. And you can see that we categorize the patient according to the ministry guideline also, these 3A and 3B, 3C. So that these according to methylprednisolone for the moderate category and the IV methylprednisolone for the severe category, that is the saturation below 92. So our case series was among about 400 desaturating patients below 96. We collected data on about 208, and we selected them saturation below 96, and according to the severity, and we gave this treatment two options, that category B and C. So then time taken to recover saturation over 94. And it is staying at that level for over 48 hours, we took as some credible improvement of the patient. So then these are our some couple of slides which shows our findings. The age distribution of desaturation patients, can remember over 60 are the biggest number, up to 80. And then among them, 60 to 80, the recovered patients numbers are about half. From you can see that 60 to 69 out of 57 got recovered only 32, and out of 70 to 79, out of 61 only 26. So so that is altogether 140. So the older people get affected by the disease. Only few recovered compared to young. That is well known. And our study also confirms that. Then the SpO2 level on admission, we found that is a really good predictor the outcome. You can see that when it is over 88 saturation, the cure rate is very much better compared to when it reaches to the 70s, the outcome is very poor. Percentage of patients with oxygen saturation of 88 on admission, and then this is about 60%, out of which 88% in the right extreme corner, that you can see 82% recovered. So, and SpO2 level and comorbidities in patients who died. Now, this is another predictor, the comorbidities, and then when you compare with the SpO2 level, the comorbidities always have the edge and keep the improvement, the efficacy of the treatment down. If the number is more, that treatment recovery also poor. The days of symptoms when starting methylprednisolone in patients who died, you can see that here. The SpO2 below 88 on admission depicted in orange, the amber color, and then the blue, which shows again the SpO2 low on admission causes the more number of deaths. So mind you, the bit of thing to derive happiness to on our mind that we gave high dose of methylprednisolone on these patients. Our yield was about 81% recovery within 10 days. So we have quickened the recovery by fair bit of the time compared to 19%. So our conclusion in this study is 81% of the patients who received high dose of methylprednisolone recovered within 10 days. So we want to compare this with another group of dexamethasone patients in another hospital in the near time future. So the age, admission saturation, and the comorbidities and the serious other adverse comorbidities decide the outcome, and we didn't encounter serious adverse effects to a significant level. It was very minimal. So in fact, this study, high-dose methylprednisolone in non-intubated patients in severe COVID-19 pneumonia, carried out by Alcaterini in Italy, maybe perhaps, and he has told that in non-intubated patients with severe COVID-19 pneumonia, methylprednisolone was associated with reduced need for mechanical ventilation and less intensive care resource utilization without excess complications. So in our setting, the intensive care utilization was, we didn't have means of doing that. Whatever that we tried to do that, we ended up with failure. So then the escalation oxygen therapy, this what are the available options? This I will show you: the nasal prongs, venturi mask, NRB, and this is non-rebreathing mask, and HFNO, very expensive machine, and the Cpap. When it comes to the first 4 categories, I want to discuss with you that the importance of Cpap. So when we escalated these oxygen therapy according to the oxygen saturation, respiratory rate, arterial blood gas, and chest X-ray, those are the parameters we use to escalate the oxygen therapy. We minimized the free radical lung damage, and we prevented the fibrosis. So that when it comes to giving oxygen, initially we didn't know the importance of lung expansion and recruitment. That is, lung get atelectatic and that closed down. So we gave low flow oxygen and we ended up in trouble. But later on, we realized that, and we started on, these are the low flow oxygen methods, where you can go up to about 80% or near 100% delivery here. And then the high flow oxygen, near 100% oxygen, and can be delivered with this HFNO. And then this is the machine, the Cpap machine, came to light towards the latter part of this illness epidemic, and where you used to expand the lung. So you must give intermittent Cpap and then give the oxygenation. Then only the patient improve. So we got a lot of improvement following that. Then I would like to go to the case study 5, that a very interesting patient, young girl coming in RAT positive, 3 or 5 days with low blood pressure. She had a fair bit of drop of blood pressure on sitting, and then her saturation was normal, and there were ECG changes, and then CRP was 32. Then we used the IV methylprednisolone, IV immunoglobulin, and IV noradrenaline, vasopressin, and aspirin and atorvastatin, because these are the ECG changes what she had, and she went into the heart, the nodal rhythm also, and her blood pressure remained low for a time until we managed to get her up, and then she made a good recovery with this treatment of this here is the circulation expansion and the disease modifying drug, that's methylprednisolone. So this is when I describe this MIS A, it is acute circulatory collapse, which is associated with myopericarditis, heart block, coronary aneurysm, and ventricular tachycardia. And there's a rash or abdominal pain and vomiting, diarrhea is the very, very common symptoms. And mind you, you can have seizure, encephalopathy, and meningism as neurological illnesses. In the definition category, it comes as it's over 21 years of age, it's severe illness, positive test for current or previous infection, COVID, severe dysfunction of unknown organ, and labs showing the severe inflammation, that is the ferritin, CRP, and the LDH, and in the absence of severe respiratory illness. That is the definition of MIS A. So it's a overexuberant reaction kicked off by recent SARS-CoV-2 infection. So when you compare that with MIS C in children, both have respiratory and liver illness. Can have the illness, but it's minimal. But when it comes to the circulatory collapse, both have the equal degree of circulatory collapse and shock. And in MIS C, more cardiac involvement is the notable thing than the adults. But when it comes to adults, it's a the other way around. It's the adults more this thing, and the mucocutaneous involvement is very, very common in the children, right? It's a 66% according to one of the studies recently. Then the differential diagnosis of this peripheral state of shock, MIS A, the diagnosis comes to septic shock. You have to consider acute myocardial infarction with cardiogenic shock and acute febrile illness with severe volume depletion. And the labs we use is again the serology and the chest X-ray echo and the blood urea electrolytes with COVID antibodies. And not only the PCR here, the COVID antibodies do play a role. So you can see at the corner, the COVID, the MIS in the middle, we use PCR and antibodies both, when especially the patient needs HDU care, ICU care, etc. So this is how the the importance of PCR in the various phases of this illness with a big span, starting from viremia to the pulmonary and the lung disease, then the multisystem inflammatory syndrome, and interstitial lung disease and the long COVID, where the antibodies will play a bigger role in making the diagnosis. So the treatment, I said, that volume expansion with crystalloids and colloids, and perhaps IV immunoglobulin is a very, very important drug, both in children and adults, and corticosteroids, inotropes and vasopressin, and sometimes ventilation is needed. Then I come to the other category, that is interstitial lung disease, which comes around, maybe perhaps on the 10th day, but it's up to 28 days with post-COVID fibrinous organizing pneumonia. But it's very, the technical term, is 39% had ongoing symptoms. And in some, the ILD is permanent damage to the lung, and ILD is developed in 4.8%. Chest X-ray lung function in the HRCT direct you to the proper diagnosis, and early pulsed IV methylprednisolone. Again, once you have treated the early pulmonary phase, and this phase also, you can give 250 milligram BD. IV methylprednisolone used in many patients and prevented them from going into severe the longer disease, that is interstitial lung disease. We used MMF as a steroid sparer, and pirfenidone, it was a very helpful drug to prevent the lung fibrosis when it is started fairly early. And this is a chest X-ray appearance of ILD, and then the CT scan appearance is a fair gross damage to the patient's lung. You can see here. And then comes the long COVID syndrome. That is 28 days onwards. It's a very ill and asymptomatic patients do get COVID, this 19 long COVID syndrome. That is a sinister thing in these patients, and a scare that not only the very ill patient, asymptomatic, do get long COVID syndrome. So it's a very interesting topic in all over the world, because now the pandemic is receding, and now we are going to encounter more and more long COVID patients, and it's a post-acute sequelae. More women get involved from right. Sorry about the inconvenience that we lost our power supply, this area in Kandy. And okay. That's correct. Thanks to my daughter, she quickly connected back me again. So where we stopped, it is more women from 20 to 60 years got affected. Among the 5 to 80% of the survival, these do get this long COVID syndrome. They have multiple complaints and disabilities. That is the special scenario here. And they can come to various disciplines in various manifestations, starting from neuropsychiatry to the gastrointestinal, rheumatological, and other areas. They have brain fog. And I came across many patients with this brain fog, memory loss, and fatigue. And cough, joint, and muscle pain are the other the manifestations of this syndrome, and lack of stamina and interest of the day-to-day work. So how do you deal with this? What are the details? The new onset, they can go into new onset diabetes, but these are the main associations. depression and anxiety, shortness of breath. We can end up with blood clots, causing enormous trouble in the vascular lesions like stroke and the myocardial ischemia, and respiratory, nervous system, gastrointestinal, and mental health do get affected. Etiology, when you consider the etiology, it's very interesting. It's a persistent infection is the one that which everybody tend to speculate, because somebody might think that this is a prolongation of viremia, but it's not. It's a persistent inflammation due to maladaptive immune response of the host. So the patient's maladaptive immune response per se is the culprit rather than the virus. Similar to post-viral syndrome in chronic fatigue syndrome, the same thing happens. Early autoimmune disease, it simulates early autoimmune disease by leading to sort of an autoimmune disease activity, high disease activity. You get a lot of antibodies becoming positive, like C ANCA, P ANCA, and antiphospholipid antibodies. So it's alarming. And then there are a lot of studies going all around the country. And they have experimented using the mice, and which led to this venous thrombosis. So it's a thrombotic disease, arterial and venous. So this is the study in US, 86,000 people, or after 30 days of the illness, and then up to 6 months, non-hospitalized category group, and there are about 60% increased risk for death. So it's pretty alarming, isn't it? And then when, there's 20% increased outpatient visits to the OPD, and there's about 8.39 excess deaths per thousand. In the hospitalized, it is worse, 51 increased risk of death, and then 29 excess death for 1,000 people. So no wonder that it draws the attention of the US government, and they have allocated a big sum of money by the federal government to investigate this disease, and we'll hear more news about it. And this is how you diagnose, and then how you make use of the serology or the PCR for that. It's the PCR has limited value or no value there, but it's the antibodies. So you do COVID antibodies here, and you do autoimmune profile like ANA anticardiolipin antibodies, which shows that it's a possibility of antiphospholipid syndrome, and then the C ANCA, then the anticentromere antibodies, again showing that it's close to some multi-organ immune disease. Then the treatment. Treatment, of course, there are no guidelines, and there are speculations, and various faculties think that these treatments would help. And I also gathered various things out of this literature. And then ivermectin do play a role, and then it will prevent severe infection. So that consequently, corticosteroid has a role. Antidepressants have a big role to play. Pregabalin is a very effective drug to deal with their pains, muscle pains, and the neuralgic pains. And then the non-steroidal anti-inflammatory drugs and long-term antiplatelets and statins, of course, can prevent this vascular disease, thrombosis. All the patients who come to me, and I consider the COVID as a pro-thrombotic condition and a high risk factor, non-conventional risk factor for the vascular disease like myocardial infarction and stroke. So I do start aspirin and statin in everybody, unless it's contraindicated. So the pain, weakness in the limbs, fever, melangia, and loss of appetite, and vascular the disease like ischemic cardiac events, systemic capillary leak syndrome. This is a very important one. When we came to, the vaccination-induced the diseases, of course, you would have seen by this time the vaccination caused a lot of concern in all around the country. People do come and say various illnesses, starting from the pain at the site and the febrile illness and the fever, loss of interest, myalgia, and loss of appetite, and lack of stamina. But none is worse than the systemic capillary leak syndrome, which causes shock and the effusions and leak of fluid. And there are a lot of case reports around the globe, and you can see on the literature. patchy COVID pneumonia do occur in the vaccination patient, and then I have seen, and some people desaturate to some moderate degree. And I don't know whether there are many people that had a serious fatal illness, but among the neurological herpes zoster is the most common, and I have seen about more than 10-15 cases of herpes zoster following vaccination. Facial nerve palsy is a common one, and the strokes. So again, the use of the workup with antibodies and multidisciplinary approach and workup is needed to diagnose this. So the last point that I want to highlight, when we came to the end of the spectrum of the disease, that is long COVID syndrome, the post-COVID-19 status is an independent risk factor for vascular disease. I want to reiterate that it can cause acute MI and sudden cardiac death. I'm sure that you all share my experience, your experience with me, and the people who ended up with strokes. In my ward, I saw a couple of patients and herpes zoster and the acute Guillain-Barré syndrome, that is peripheral neuropathies. When it comes to that's all. Yeah, and I'm very thankful that you all listened, and it's I think I'm available for any questions you to raise.
Yes, sir. We have quite a few questions coming in. For the first question is how the reason for COVID patients' electrolyte imbalance and the possibilities of desaturation due to pulmonary edema rather than acute pneumonia.
Yeah, the electrolyte changes in COVID patients, of course, is not a very common in the COVID pneumonia, unless you the patient get deprived of the proper fluid intake. But when it comes to the middle stage, intermediate syndromes like long COVID or the MIS, it is the most important finding: electrolyte changes and the blood urea and the serum creatinine rising, leading the patient into AKI. What's the other question? Sorry.
The other question is possibilities of desaturation due to pulmonary edema rather than acute pneumonia.
The possibility of desaturation. In fact, here it's not the pulmonary edema. It is a sort of pulmonary thrombus. It makes a huge barrier to from the atmospheric oxygen entering to the capillary circulation. So there are secondary damages like exudative damage due to the lung injury. The pneumocytes get injured, and then hardly you can see any the pneumocytes. And I should have put the slide. I just forgot to do that. And one of our patients' slide, which our JMO showed, my colleague, very interesting. It's a totally pink lung without any single air space, so that there's no fluid or edema, like in the cardiac edema, cardiogenic edema. It is a solid lung. It is solid lung, fully infiltrated. Okay. Dilni?
Yeah.
Yeah. Does that answer?
And,
Hello.
we have one more question, sir, about ivermectin in the preventive therapy.
Yes. The preventive therapy, it is the most convincing that you saw that my slide. It's about 80% of the people do get the effective prevention of transmission. So that not only shortening the viral disease, your other people don't get infected. Having read the very positive outcome in India, in all over the New Delhi, Uttar Pradesh, Uttarakhand, and then the Goa, I started that in many families that whom I happened to treat. And when one got infected, it prevented getting transmitted to the rest of the family. And not only the person who got infected had a mild disease, so just maximum only 48 hours. Then after that, the others failed, others didn't get infected. This is a very promising experience that we derived, but of course we are very eagerly waiting for the proper randomized multi-center trials with big numbers should give us firm evidence. Prophylaxis it's very effective. How you give it is, of course, if you are interested, you have to take one tablet, 12 milligram. That is, your dose is 300 micrograms per kilogram body weight. So it comes to 12 milligram for about 60 kilogram body weight person. And after 48 hours, you take another one. Then from that day, the second dose, you take every week 12 milligram tablet. And it is non-toxic. There's absolutely no toxicity or side effects, serious side effects. And it do prevent you from getting infected. This was adequately proven in India in the health workers. There is a study, nice study.
So we've got one more question for you, sir, about these mild or asymptomatic COVID patients, whether they also develop the long COVID syndrome, and how do you manage? How do you identify?
Yes, that's the thing. There's no infection or the illness as such. They do come with, the presentations that I told, the fatigue and brain fog and memory loss and all that. And this the main stage of diagnosis is that you prove the recent infection by doing COVID antibodies. And that is the only clue that it may indicate that unless the patient is vaccinated, that shows very clear evidence that the patient got infected. If the patient is vaccinated beyond 2 weeks, that antibodies can represent the vaccination effect. So that again, the help is very minimal from that, the possibility of antibodies. So, but you have to go for the other they have autoimmune profiles getting activated and so on. And it's a clinical diagnosis perhaps at the end of the day.
Does the CT value help? We have one more question, sir, for you.
CT value, yes. If in case that this PCR become positive, by the time the 45th day, 40 or 40th day, the CT value, of course, is doesn't show much promise. But between 30th and 45th day, CT value could be very high, so that it indicates the patient has had the very the viral clearance is maximum and very low burden of viral RNA in the system, and it indicates the previous recent infection. But beyond that, I don't know whether it's going to show you how much of amplification you do by using PCR. It might not show viral RNA. So up to 45 days, maybe perhaps the maximum that utility.
We have one more question. There are actually several questions coming in, sir. So hope you can take in one more question.
Yes, I don't mind. Go ahead.
Yeah. Post-COVID, what is the significance of doing D-dimer level? In what circumstances to do other than when suspecting cardiac complications?
Yeah, D-dimer, of course, is our common usage is to see that whether the patient get pulmonary thrombosis, right? When we suspect pulmonary embolism, in the sort of low possibility of pulmonary embolism, that the D-dimer doesn't help. But when it comes to a bit of higher possibility, that you might do the D-dimer in a significant value, sort of utility. So when it comes to the thrombosis, but its value is very high, because it indicates the possibility of DIC and thrombosis in the system. So when the patients fail to improve towards from the 15th to 20th day or so, and we did D-dimer to diagnose this pulmonary thrombosis, and then we resorted to HRCT. So D-dimer is a preliminary test before you proceed to HRCT, and the threshold is very low, if the D dimer is high, the possibility is very low, and the D dimer is high, that indicates the ongoing severe infection. Severe infection, of course, that is how it goes, leading to DIC.
One more question, sir. Keeping the long COVID syndrome in mind, what advice and what management can we give a patient on discharge after treating for COVID?
Yes, after treating for COVID, if you shorten the disease, the longevity of the disease, the chances of them going into long COVID is less, according to the literature. And if this, if the patient has got severe disease, then again the chances is more. So the length of the suffering and the severe disease, of course, goes together. And then you must advise the patient that these symptoms could be a possibility, and you have to resort to medical advice. Don't think that it is not treatable. It's plenty of ways you can treat, provided the patient present, rather than getting depressed and then resort to various other modalities of treatment. In my experience, I treated a fair number of patients with long COVID, and they make a good response. And a neuropsychiatry, you have to do antidepressants, and then, you know, the pregabalin, and perhaps a short course of steroids do help. So you have to educate the patient that they need to come quickly, the way that they might present to the rheumatologist, they might present to the cardiologist or pulmonologist or the general physician. So wherever they go, the people have to have a multidisciplinary approach. And in fact, in the world, they propose multidisciplinary clinics for them. I don't know whether it's possible, feasible in our setting, our poor resource settings, but that is how it's going to be managed in US.
One more question, sir. Does a patient have lifelong immunity for one particular strain when contracted? And I will give another second question related to that. Can they get COVID reinfected by another strain? If so, does it have a bigger strain on the infectivity and complications?
Yeah, you are asking this the scenario what we encountered in dengue. Dengue, exactly. Of course, when you get one the strain, that is a strain 1, then as you get infected with the strain 3, you get severe MOS disease. That is a leaking. In fact, here, when you encounter, we have encountered the various strains. That is 1 or 2 patients coming infected for the second time, but we didn't see a bigger sort of a morbidity in those patients. No, here so far the literature what I read didn't show that the second infection with another strain leads to very escalated disease, just the mere reason because the patient was previously infected by, for instance, alpha. And when the delta came, it was not the alpha which caused the severity of the disease, but the delta per se was very, very severe on the system.
So the next question. Okay. Next question is on vitamins. Does giving the vitamins help, and have anybody assessed that?
People have given vitamin, the very much used vitamins are vitamin D and C. And there are a lot of studies coming from this frontline COVID Critical Care Alliance in US, Eastern Virginia Medical School. There are studies that they show, because of this zinc, that is, it's a mineral, but mainly the vitamin D and C does help in reducing the lung disease. But I don't think, to my knowledge, in Sri Lanka, people have carried out studies on vitamin D. But it's adjunct to therapy only. I don't think that by itself, the per se, it's on its own capacity going to make the lung thrombosis cured. So people should not rely too much upon it. It's adjunctive therapy.
Well, I think I think I've managed to project all the questions to you, sir. So thank you very much for that very informative presentation. And I think we have almost 70 participants, and we are bombarded with questions. And I think that's all the time we have. And thank you very much for answering all our questions. And that was a very, very informative presentation for not only all the GPs, and I think we have so many participants who are working with providing in-ward treatment to COVID patients also today. So I think the information that you gave us is quite very valuable. Thank you very much, and thank you for joining with our webinar series of the College of General Practitioners of Sri Lanka. And I would like to thank Dr. Reddy's Laboratories today for their sponsorship. And thank you very much for your time.
Yes, yes, Dilini, if I take a couple of 1 minute to just thank Mr. Wazim from Dr. Reddy's for taking the initiative to invite me for this webinar, and then the Dr. Reddy's and the whole officials in Dilini and Shobhavi and Miss Anton, and so I'm very glad that you the other day you gave a good briefing of how the webinar goes and see. And my daughter, the most big strength behind me. When the power went off, she is very swiftly connected. There was, very few delay, and I'm very thankful to her. And then my SHOs, Dr. Amir, Gayan, and others, many others, and all the RHOs and HOs who did the hard work in my ward staff. Not to forget my big colleagues, my sincere colleagues, Dr. Tushari Vanikasekara, my co-physician, and then Dr. Manil Piris, our consultant chest physician, and we three managed the 3 HDUs with the help of great help from our other EVPs, gastroenterologists, neurologists, and the rheumatologists. We all worked as a bunch. That was unique in Matale, the companionship and taking part of this national need. And I salute them and thank them very much to all of us. And I do thank my other consultants who gave the awards to setting up these 3 HDUs, and not only the other ways. And not to forget the 2 directors, and who did a very big yeoman service. And so thank you again, Dilni, for your kind words.
Yes, sir. Thank you so much for sharing all your amazing work that you and your team have done at the General Hospital Matale. We are very happy to have heard about all the amazing work that you have done and the research work that you're doing with your COVID patients. We wish you all the best, and thanks again from on behalf of the College of General Practitioners. Thank you for joining our webinar today. And I would like to thank all our participants. Thank you very much for joining the webinar today. See you soon.
Thank you.